So I have a question for Dr. Libby and Dr. Kumar. So I recently saw a patient who was 70-year-old, came to the ER with profound fatigue, was found to have hemoglobin of 6.4, and on CT scan she had multiple blastic lesions. And she was in renal failure with creatinine of 6.8. So biopsy of blastic lesions showed multiple myeloma, kappa chain myeloma. How will you treat this lady, besides blood transfusion and other supportive management?
Well, I think you're describing somebody with renal dysfunction or renal failure associated with a multiple myeloma, probably from the light chains. One of the keys is to use proteasome inhibitor-based therapy. Most of the studies, virtually all of them, are with bortezomib. A lot of that studies have come from the Greek investigators, but bortezomib-based therapies are the best approach. They can give you the most rapid response, and you can salvage kidney function in many of these patients. I consider that to be severe renal dysfunction in newly diagnosed multiple myeloma relapsed is essentially a medical emergency, and these patients should be treated very aggressively, perhaps admitted to the hospital. I may give them intravenous bortezomib to try and get an even more rapid activity. I'm only going to do that briefly for a few weeks, but that, along with hydration and consultation with my nephrology colleagues, would be my approach. Right now, it's not clear that using ultrafiltration in an attempt to remove the light chains is clearly the right way to go. There was a presentation at ASH of a new columns, I believe, where you can remove the light chains that have a better outcome, but they're not approved in the United States. So I think whether or not to use them in this situation varies on the center and who you're talking to, although I'd be interested in hearing at Mayo Clinic if there's a reproducible approach in terms of trying to dialyze off the light chains in patients like this.
Yeah, I completely agree. I think the key for the long-term survival of these patients who present with renal failure is the ability to rapidly reverse the renal failure. So a couple of kind of take-home messages. I think somebody presents with renal dysfunction. Most of those patients are Cas nephropathy, and you would see high levels of serum-free light chain. In our practice, patients with a light chain that's over 100, we generally tend to do plasmapheresis in those patients in addition to starting them on a bortezomib-based therapy. Now, there's not a lot of phase 3 randomized data. There's a Canadian trial which essentially was a negative trial, but that was, you could argue, was in the context of not the modern therapies. Our own experience has been that it does help you bring the light chain down relatively fast. And we published our experience a couple of years ago. It's obviously not controlled. So that's our, in patients who come with relatively lower light chain levels, it will be, all these patients, I think it's useful to do a renal biopsy to be absolutely sure that's what you're dealing with, because some of these patients, especially in the setting of lower light chain levels, could have concurrent amyloidosis, they could have light chain deposition disease, and also to get a sense in the older patients, how much of this is pre-existing renal dysfunction because of something else versus everything being Cas nephropathy. Could be, in addition to being diagnosed, it could be prognostic as to how much you expect it to reverse. But I think bortezomib-based combinations, either bortezomib cyclophosphamide dexamethasone, bortezomib thalidomide dexamethasone, or bortezomib doxil dexamethasone are the combinations I tend to use.
So we decided to use Cytoxan, bortezomib, and dex, and she did pretty well from that standpoint. Now, how often do you see osteoblastic lesion, and what are the risk of fractures for osteoblastic versus lytic lesions?
So osteoblastic lesions, it's very uncommon,
Right.
and I'm not sure how to explain this to somebody. Often when you see the osteoblastic lesions, it tends to be like a very limited number of lesions which are,
she had widespread. It was a surprise to me, so that's why we biopsied a couple of spots. It was all multiple myeloma.
Yeah, obviously, that's the right thing to do. But I don't know if it has any implications in terms of the longer-term outcome. But irrespective of whether there's bone disease or not, use of bisphosphonates do help patients. Obviously, in the setting, somebody comes in with renal failure, don't want to jump into it right away. You could wait and see how much it reverses before you get them started on bisphosphonates. Sure. I generally tend to use permethrinate in the setting of minor dysfunction compared to zometronic acid. Obviously not in somebody who is 6.8.
Sure, thank you. Dr. Samuels.
I have a few just practical type questions. So to address the renal failure presentation first, quite often, at least where we practice, getting light chains, maybe 3 or 4 or 5 days before you get them back. And it's my impression that if you're going to do the plasma exchange, you want to get started right away, particularly if the patient has significant failure. So what are sort of practical criteria for when you would kind of pull the trigger on that?
That's a good question. I guess we are kind of spoiled getting the light chains back in 4 hours. So so I think you can get some, when in doubt, I would rather err on the side of doing the plasma exchange, because, what is it compared to all the expensive therapies we use? It's actually a relatively cheap technique to use.
Mm-hmm.
And as I said, if you can salvage the kidney in the first couple of weeks, you have the best chance of doing that. The second thing is, generally patients who present with very high levels of serum-free light chain often tend to have, not as much of the heavy chain spike, so it could be an indirect evidence, but I wouldn't rely entirely on that.
So the second practical question is, in surveillance, is there some guidance as to when to use MRI as opposed to radiographic skeletal surveys?
So good question. So I think, I think about it from the point of view of diagnosis, right? So if you see lytic lesions in somebody, you're going to treat them as myeloma. So in that setting, we want to use a technique that is more sensitively identify bone disease. So right now, with all the techniques we have available, the whole body Lowdose CT scan is probably going to be the future way of doing that. In some places, it's hard to get it because of the way we code for these things for Medicare reimbursement. So a PET CT, the CT portion of the PET CT essentially is the most sensitive way to look for bone disease. So, so I think obviously a skeletal survey shows lytic lesions and you don't need to do anything more. Right. It's clear. In somebody who you suspect smoldering multiple myeloma, or you're trying to distinguish between smoldering or active myeloma, a PET CT and the CT portion of the PET CT would give you a better sense if these skeletal survey is negative or the lytic lesions. In the absence of lytic lesions, then in terms of prognosticating patients with smoldering myeloma, the MRI of the spine and pelvis will help you identify non-osteolytic bone lesions, which, or marrow lesions, which we know are predictive for progression, but also, with the new diagnostic criteria, if you have more than one of those lesions, then you are going to treat those patients as myeloma. So I look at this stepwise approach.
Yeah, I think the whole body low-dose CT scanning is interesting. I'm glad you brought that up. Do you have it in place at Mayo? We're putting that in place at the SCCA as well. So that's a technology that may replace a lot of what we've been doing so far. But as Dr. Kumar pointed out, you have to figure out how to bill for it. Apparently, for most of the newer generation scanners, it's not difficult to tweak the scanner to accomplish that kind of a study. So that's something to be looking for at your center. I did want to mention that in patients with renal dysfunction, that you don't think that you cannot give immunomodulatory drugs. So the problem, the issue though, if someone's in the ICU or who's hospitalized with acute renal dysfunction, is you're not going to get a rapid response to an immunomodulatory drug. But they work beautifully in people with renal dysfunction, but it takes time. And so I use them frequently in people with renal dysfunction and even renal failure, but you have to adjust the dose, and it takes time. They're not the drug that's going to potentially salvage a kidney in the ICU.
Right. And finally, if you could share your techniques for the daratumumab infusion reactions, I think we'd appreciate that.
Would
So
you
the-
repeat
You had said that there was a sort of management learning curve for managing the infusion reactions with daratumumab.
Yeah, so some of the things you can do is montelukast. There was an abstract about that, and I think there's some more research going on about using that as to prevent allergic reactions given the night before and on the day of the daratumumab infusion. It isn't a home run, but it does appear to obviate some of those side effects. I think that the nursing staff in the infusion suite need extra training specific for daratumumab to learn when to stop the drug and when to observe the patients, because the recommendations from the company are not, they're not identical to rituximab. It is a different agent, and I think so gaining comfort with it and making sure you're aware of all the standard recommendations is critical. Some centers, because of bad experiences, or even admitting patients to the hospital or sending patients to other clinics, but I think the company's been very good with us and works all around Seattle with educating the different clinical centers on how to utilize it, and I think that can make a big difference for your center, is to contact the company, get an in-service, learn how to use the drug. It is different, and I know whenever I'm using a new drug, I get nervous, so I'm not surprised the infusion staff do too. Any comments about that?
The only thing I want to add is, it's a one-time deal. So it's very, very few patients, if any, get a recurrence of the infusion reactions. It's managing the first one. A lot of people do it differently depending upon what logistic support they have. If you can transfer the patient to a hospital setting without much difficulty, then you start with, you do it the way the full dose. Some people tend to split the dose over 2 days to make it to kind of get over that hour restriction thing. And sometimes people just give half the dose with the first infusion, and then because you're going to get another dose in a week. So they're all kinds of things have been used.
Now, I have another question. So osteoporosis is one of the manifestations of multiple myeloma, and many of the patients who get multiple myeloma are older. When would you think that the osteoporosis in a particular patient is from multiple myeloma or not?
Well, it's especially challenging in a woman, of course, and then I think both, though, in women and men, the clinician needs to think about all the other causes, and that's true in everything in myeloma. If someone is anemic, but has an elevated level of plasma cells and an M spike, you've still got to wonder, do they have a gastrointestinal lesion or something else that's causing it? In a woman, is it related to menopause? Do they have other risk factors that could cause it? In a man, do they have menopause and loss of testosterone, which is a cause of osteoporosis in men? So that's something you have to think about. Now, osteoporosis is no longer really used as a diagnostic criteria for multiple myeloma, although it was in some studies in the past. But I think in general, most of the recommendations now are to strongly consider, certainly anyone with a lytic lesion should get bisphosphonate therapy, because it markedly decreases the risk of further skeletal fractures. And that's something I worry a lot about in my patients, is getting spinal fractures, because it can change their quality of life, sometimes permanently, from just chronic severe pain.
I mean, the bottom line is, whenever you see osteopenia that is out of proportion to what you would expect in a patient in the setting of monoclonal gammopathy, I think it's reasonable to ascribe it to that. Would you start somebody on treatment if they have mucus or smoldering and have osteopenia? No, I would just give them bisphosphonates and then continue to watch them.
Perfect. Well, if there are no more questions, now it's time for lunch. The lunch is available in exhibit room, and we'll come back at 1 o'clock.